So we'll be talking about osteoporosis today. So just a quick introduction on some bone basics. Bone turnover or remodeling is normal, and usually results in no net loss of bone. In bone, there are two major types of cells. There are osteoblasts, which build bone, and osteoclasts, which resorb bone. In normal bone, there's a balance between the osteoblasts and the osteoclasts, which usually results in no net loss of bone. Bone resorption can occur pretty quickly, and bone formation can take a lot longer, about 3 months to build bone. So again, just another slide to sort of highlight the major players in bone remodeling. We have osteoclasts, which increase bone resorption, osteoblasts that increase bone formation. Parathyroid hormone is important in maintaining calcium levels within the body. Vitamin D promotes mineralization of the bone. Without adequate vitamin D, newly formed bone is not mineralized, so it does have a significant role in bone remodeling and bone formation. And another hormone called calcitonin can inhibit resorption. So what is osteoporosis? Osteoporosis is a skeletal disorder. It's characterized by decreased bone strength, which predisposes to an increased risk of fracture. So bone strength is determined by bone density and bone quality. Osteoporosis occurs when bone resorption exceeds bone formation, and that results in a net loss of bone. So as you can see in the image here, normal bone versus osteoporotic bone, there's significantly more space between the bone and the osteoporotic patients, and that does increase the risk for fracture. So osteoporosis is a major public health problem. According to the National Osteoporosis Foundation, 10.2 million Americans have osteoporosis, and an additional 43 million have low bone mass, also known as osteopenia, a terminology you may have heard. About more than 2 million osteoporosis-related fractures occur annually, and more than 70% of these fractures occur in women. A recent study showed that the annual costs for caring for osteoporosis-related fractures are greater than the annual costs for caring for patients with breast cancer, heart attacks, or strokes in women greater than 55. So a significant major health problem in our country. Hip fractures result in 10 to 20% excess mortality over a 1 year period. There's a 2.5-fold increased risk of future fractures after someone has already had a hip fracture. 20% of patients require nursing home placement after a hip fracture. So there's a significant morbidity that comes with it. It's very hard to maintain or go back to your usual state of life prior to a fracture. 60% of patients do not regain independence after a hip fracture. So our job as endocrinologists is to try to, identify osteoporosis and prevent fractures. And one of the problems with osteoporosis is that unless there's a fracture, it's often a clinically silent disease. So you don't know that you have it. So what are the causes of osteoporosis? So being postmenopausal or having gonadal insufficiency from certain treatments is a major cause for osteoporosis, and probably the most common cause in our country. Hyperparathyroidism, which is a condition in which the body makes too much parathyroid hormone. As parathyroid hormone helps to maintain normal calcium levels in the body, when there happens to be too much of this hormone, the body has more calcium than it needs, but still thinks it needs more. So the parathyroid hormone will start to take some from the bone and can accelerate bone loss. Steroids, glucocorticoid excess can cause osteoporosis, calcium deficiency, and vitamin D deficiency. So while this is a busy slide, I to sort of highlight that there are a number of other potential secondary causes for osteoporosis. I won't bombard you with information on this chart, but I wanted to go over a couple things. There are certain medications that are fairly common, such as proton pump inhibitors, which we use for treatment of acid reflux. These can contribute to osteoporosis over a prolonged treatment course with these medicines. Certain chemotherapies can cause osteoporosis. Other endocrine or hormonal disorders can cause osteoporosis, including diabetes, hyperthyroidism, alcoholism, chronic liver disease, celiac disease, or other malabsorption syndromes can also contribute to osteoporosis. So in screening for osteoporosis, we want to screen all women who are over the age of 65. We also want to screen all postmenopausal women that have a history of fracture without major trauma. We consider this to be a fragility fracture, so you may hear that terminology throughout this talk. Postmenopausal women with a history of osteopenia that have been identified radiographically, so on x-rays or imaging done for other things. Postmenopausal women who are starting or have been taking long-term systemic glucocorticoids, so steroids, for greater than or equal to 3 months. Other perimenopausal women or postmenopausal women who have risk factors for osteoporosis if they're willing to consider treatment. And that could be, other risk factors would be low body weight or low BMI. As I mentioned, long-term glucocorticoid treatments, history of osteoporotic fractures, early menopause, current smokers, or those who have excessive alcohol consumption. We also consider screening for secondary osteoporosis, which includes checking a comprehensive metabolic panel, a CBC to check blood cell counts, vitamin D, testosterone levels in men, 24-hour urine calcium levels, and in certain scenarios, we'll screen for thyroid disorders, parathyroid disorders, excess cortisol, or celiac disease. And those would be based on clinical history. So this is what a DEXA scan looks like. You lay on your back, feet elevated, and they take pictures of the hip, the spine, and the femoral neck. So generally, Medicare will pay for a DEXA scan every 2 years in postmenopausal women. They do measure the non-dominant hip. Follow-ups should be done on the same side. And ideally, all DEXA scans will be done at the same location, on the same machine, and by the same technician to allow for the most accurate comparisons. And that sounds like a pretty lofty goal, but most radiology centers try to aim for this. So they'll try to schedule you at the same location. They usually have one technician that does most of them, and that really does allow for the most accurate comparisons from every couple year DEXA scans. So diagnosis of osteoporosis is based on the DEXA scan. We're looking at T-scores. So normal T-score would be -1 or higher. Osteopenia or low bone mass is between -1 and -2.5. Osteoporosis is when the T-score is less than -2.5. And severe osteoporosis is when the T-score is less than -2.5. Plus there's history of a fragility fracture or a low trauma fracture. We use T-scores, T-score categories in postmenopausal women. The T-scores use young race-specific female database for comparison, and that's how they developed these goals. So a T-score of -2.5 or lower in the lumbar spine, femoral neck, or distal 1/3 of the radius is diagnostic for osteoporosis. Also, who have a history of a low trauma fracture or fragility fracture in the hip or the spine automatically get a diagnosis of osteoporosis regardless of what the T-scores in the DEXA scan show. If there's a T-score between -1 and -2.5, and there's a history of a low trauma fracture in the proximal humerus, so around the wrist, the pelvis, or the distal form, so lower in the arm, also are diagnosed with osteoporosis. And if there's a T-score between -1 and -2.5, and they have a high FRAX score, which is a fracture risk, and I'll go into that in just 1 second. So FRAX scores calculate the 10-year risk of fracture. We use them in postmenopausal women and men over the age of 50 who have a history of osteopenia based on the DEXA scan to determine their 10-year fracture risk. FRAX was validated in 11 different cohorts. Only one included men, but we still do use this for men. It reviews several different factors, including age, weight, height, family history, smoking history, alcohol use, and uses all of these factors to determine the 10-year fracture risk. So FRAX scores that warrant treatment would be the risk for a major osteoporotic fracture of greater than or equal to 20%, or hip fracture, or risk for hip fracture greater than or equal to 3%. So if you have a history of osteopenia and you have high FRAX scores, that would warrant treatment for osteoporosis and fracture prevention. So osteoporosis in men, men tend to have hip fractures about 10 years later than women, but they're more likely to die from hip fracture. So it is important that we recognize this in men. The National Osteoporosis Foundation and American College of Physicians recommend screening men greater than 70. We'll screen men less than 70 if they have a risk factor of hyperparathyroidism, long-term treatment with steroids, prior to a lung transplant, history of a fragility fracture, or if they are on androgen deprivation therapy for prostate cancer. 40% of osteoporosis in men is due to a secondary cause, as I mentioned on some of those previous slides. And the biggest issue that we've come across in men is getting insurance coverage for a DEXA scan. Okay, so now we'll move on to some treatment for osteoporosis. And non-pharmacologic therapies or conservative treatments that we offer patient, or that we recommend to patients, include adequate calcium intake, and the recommended calcium intake is about 1,200 milligrams per day, and that includes diet plus supplement. Adequate vitamin D intake, and that's usually about 800 to 1,000 international units per day. Weight-bearing exercises, which include walking, jogging, resistance training, or jumping, also help to improve bone and also help to strengthen the muscles and prevent falls. We recommend smoking cessation, limiting alcohol consumption, and fall precautions. So fall precautions, we're usually telling patients, make sure there are no loose rugs around the house, using handrails to go up the steps, shoes with not walking around in socks that could increase risk for slipping, basically anything that can help to prevent falls. So FDA-approved medications for the treatment of osteoporosis include bisphosphonates, and there are several of these that we use. There's alendronate, bandronate, risedronate, zoledronic acid. I did put the brand names next to them, as you may be more familiar with. We have Denosumab, Teriparatide, Abaloparatide, Romosozumab, Raloxifene, calcitonin, and estrogen. Okay, so FDA-approved treatments for osteoporosis in men. There's alendronate, risedronate, zoledronic acid. These three are all bisphosphonates. There's teriparatide and denosumab. So for the bisphosphonates, there are 4 available bisphosphonates. There's risedronate, alendronate, bandronate, and zoledronic acid. These are appropriate first-line treatments for most patients with osteoporosis. They reduce bone resorption. Most reduce their fracture risk by about 50%. We do have to use these cautiously in patients with advanced kidney disease. 3 of the 4 bisphosphonates that I mentioned, alendronate, risedronate, and zoledronic acid, are effective at reducing fractures at the hip, spine, and also reducing non-vertebral fractures. Bandronate only shows efficacy for reducing vertebral fractures, so it's not used as commonly as the other 3 that I mentioned. Risedronate and alendronate are taken orally, and zoledronic acid is given once a year through the IV. That's IV reclass if you're more familiar with that one. Denosumab is a monoclonal antibody to rank ligand, which inhibits development and activity of osteoclasts. So basically, long story short, it decreases bone resorption, which can help to prevent fractures and worsening bone mineral density. It has broad spectrum anti-fracture efficacy, which means that it reduces fractures at the hip, the spine, and non-vertebral fractures. We don't use it in patients who have a history of hypocalcemia. And for bisphosphonates, we often will recommend a drug holiday at some point, but a drug holiday is not recommended with Denosumab due to rapid decline in bone mineral density and protection from vertebral fractures when you stop it. If Denosumab needs to be stopped, we usually start on an alternative anti-resorptive treatment, whether that's a bisphosphonate or teriparatide. We use something else to help prevent bone loss. So then there are the parathyroid analogs, which are Abaloparatide and Teriparatide. Both of them are subcutaneous injections. They're both anabolic agents that result in increased bone mass. They increase the bone mineral density and reduce the risk of vertebral and non-vertebral fractures. The studies showed a lack of efficacy in fracture reduction in the hip, but this may be more a result of study design or inadequate power, as the incidence of hip fracture was low in these trials. So I think there are more studies that are ongoing to see if the fracture risk for the hip is also lowered. Prior to use, you want to check a basic metabolic panel, parathyroid levels, calcium, and alkaline phosphatase. Basically anything that could indicate if there's possibly an issue with the bone prior to starting. We don't use this medicine in patients who are at increased risk for osteosarcoma. That includes patients with Paget's disease or history of radiation treatment. And we limit the treatment to 2 years. So both of these medicines are approved for postmenopausal osteoporosis treatment. Teriparatide is also approved for treatment of osteoporosis in men. So this is one of the newest agents that we have for osteoporosis. It's Romosozumab. It's a monoclonal antibody directed against sclerostin. Basically, it allows for increased osteoblast activity, so increasing bone. It showed a reduction in vertebral fractures. Clinical studies also showed a reduction in hip and non-vertebral fractures, but it's indicated for a reduction in vertebral fractures. It can be used in patients with history of prior radiation history. We have to use cautiously in patients who have a history of cardiovascular disease. So Raloxifene is FDA approved for treatment of postmenopausal osteoporosis and reduction of risk of breast cancer in patients that are at high risk for breast cancer. We don't use it in women with childbearing potential or history of thromboembolic disease, like DVTs or pulmonary embolisms. It does show a reduction in vertebral fractures, but does not have any efficacy in reducing hip or non-vertebral fractures. So there are a rare subset of women who may benefit from this particular medicine. We honestly don't use it all that often, but it is nice to know that it has that potential benefit of reducing breast cancer risk. So some clinical concerns with these medicines. So all medicines have some side effects. So for bisphosphonates, we use with caution in patients who have active esophageal disease, strictures, severe acid reflux, for example. Both bisphosphonates and Denosumab are associated with something called osteonecrosis of the jaw or atypical femur fractures, and I'll discuss those further in a couple other slides. The PTH analogs, Teriparatide and Abaloparatide, are associated with potential increased risk for osteosarcoma. However, the data for this comes from studies that are done on rats receiving extremely high doses of this anabolic agent. Studies using doses that are 3 times the dose that we use in humans did not cause malignancy in the same strain of rats. However, due to this potential concern for osteosarcoma, we don't use these medicines in patients who are at increased risk for osteosarcoma, which, as I mentioned, include patients with history of Paget's disease, another bone disorder, or a history of radiation. And also due to this, the treatment with these agents is limited to 2 years. Raloxifene is associated with a 3-fold increase in occurrence of venous thromboembolism, although the absolute risk is fairly low. And the last one, Romosozumab, was associated with higher rates of serious cardiovascular events when compared to a bisphosphonate group. It does carry a black box warning for patients who are high risk for cardiovascular disease or had a recent heart attack. So osteonecrosis of the jaw is the presence of exposed bone in the maxillofacial region. So usually you're seeing it like on the upper jaw or the lower jaw for that matter. The incidence is pretty low. It's 1 in 10,000 to 1 in 100,000. It typically occurs in patients undergoing invasive dental procedures, but it can also occur in patients who have ill-fitting dentures. There's a higher incidence of this in cancer patients that are treated with IV bisphosphonates, often because IV bisphosphonates are given more frequently in cancer patients, especially if used for treatment of hypercalcemia. They may be getting it every 4 weeks or so, so it does increase the risk in cancer patients. So prevention for osteonecrosis of the jaw, we recommend regular dental care. A dental exam should be performed prior to treatment initiation. Ideally, any invasive procedure would be done prior to starting treatment. There's no evidence that stopping the bisphosphonate for an invasive dental procedure will reduce the risk for osteonecrosis of the jaw, and actually the ADA recommends against stopping it. So another potential side effect is something called an atypical femur fracture. And these are low energy subtrochanteric fractures. So they occur after little to no trauma, basically in the hip or pelvic region. They usually occur after really prolonged duration of anti-resorptive agents like bisphosphonates or Denosumab. And it's thought to be a result of bone turnover suppression. 70% of patients present with persistent groin or thigh pain. Prevention of these, we usually follow guidelines for drug holiday, timing, or duration, because these, again, do tend to occur with really prolonged use of bisphosphonates, so usually more than 5 years. And this just shows the suggested duration of bisphosphonate treatment and drug holidays. So the higher risk of fracture, the longer you're going to be treated for, and usually the maximum is about 10 years. So after a 10-year period, we recommend staying off of bisphosphonate for 1 or 2 years, or changing to a different medication if the fracture risk is still high. So this is just, so while these two complications are among the most concerning, both for patients and for the treating physicians, it's important to remember that the number of fractures that are prevented with treatment for osteoporosis far outweigh the risks of osteonecrosis of the jaw or atypical femur fractures. So these two slides just highlight that. And criteria for treatment: men and women with a T-score of less than 2.5, men and women with T-scores of between -1 and -2.5 with high FRAX scores or high fracture risk, women and men with history of spine or hip fracture, and we have a lower threshold to treat women and men who are on prolonged treatment with steroids. So some special treatment considerations: men with prostate cancer who are on androgen deprivation therapy or ADT. ADT increases bone turnover, decreases bone mineral density, and increases the risk for bone fractures in men with prostate cancer. We can see the loss of bone mineral density usually within 6 to 9 months of treatment initiation. The risk of osteoporotic fractures is about 20% after 5 years. We treat when the treatment criteria are met. So the treatment criteria for patients who are on androgen deprivation therapy or other chemotherapies are going to be the same as what we're following for postmenopausal osteoporosis. So when the criteria is met for treatment for osteoporosis, we would recommend treatment. And for men on androgen deprivation therapy, Denosumab or Prolia is the preferred agent. We can use zoledronic acid if Denosumab is contraindicated for whichever reason. And for breast cancer treatments, aromatase inhibitors, gonadotropin-releasing hormone agonists, surgical removal of the ovaries, chemotherapies that induce ovarian failure are all treatments that are used for breast cancer, and all can decrease endogenous estrogen secretion, which ultimately results in decreased bone mineral density and increased risk of fracture. Some have recommended checking a DEXA scan within 3 to 6 months of treatment initiation, and in those who have other risk factors for osteoporosis. Again, we treat when the criteria for treatment are met, and bisphosphonates are the preferred anti-resorptive agent. The more sudden and severe the estrogen deprivation occurs, the greater the magnitude of bone loss. Okay, so in summary, osteoporosis is a major public health issue, and osteoporotic fractures are a significant cause of disability among the elderly. Cancer patients are also at increased risk for osteoporosis due to many of the cancer treatments that they undergo. We cancel all patients on conservative therapies to prevent bone loss, like weight-bearing exercises, calcium, vitamin D supplementation. We monitor high-risk patients for osteoporosis, and we treat patients with osteoporosis based on their T-scores, presence of fragility fractures, or elevated fracture risk. Thank you.
Thank you, Dr. Ukrainski, for that great talk. We really appreciate you being with us today. For everyone else, there's an opportunity now for questions and answers. I see one already, Dr. Ukrainski.
Yes,
there's a question about what was the maximum time that the Denosumab should be taken.
Also, we can give that up to 8 to 10 years as well, depending on the severity of the osteoporosis, how high risk they are for fractures. Again, everyone's duration may be a little bit different.
Anyone else can either ask the questions on their own, or you can place it in the chat box. While we're waiting, Dr. Ukrainski, one of the things that we've been monitoring closely is vitamin D levels. And my question to you is, what is the recommended vitamin D level that's considered to be the optimal for patients? And is it still the recommendation to check it once a year, especially in our cancer patients who are on therapies?
Right, so we're recommending a vitamin D level of above 30. That seems to be the best for bone health. There is some debate on the upper level for vitamin D ranges. Generally, we're not recommending to keep the level, above 50 or 60 for bone health, just because there are some debated possible consequences for that. At high levels, vitamin D can actually inhibit bone resorption. So for bone health, really we're aiming for somewhere between 30 and 50.
Great, thank you. There is another question here about, is there a dosage of calcium or D3 that would be considered too high? And I guess that's where you were just talking about looking at the blood levels.
Yeah. So everyone is going to be a little bit different in that. If you're severely vitamin D deficient, you're going to need more vitamin D to get to the 30 to 50 range. Once people are in the 30 to 50 range for vitamin D, most people can be maintained on that by taking 1,000 to 2,000 units of vitamin D a day. For calcium, we're recommending 1,200 milligrams daily, and that's through diet and supplements. So again, it depends on each person individually what their dairy intake is, or are they getting most of their calcium through supplements?
I'm trying to understand this question, but someone was asking about not start at menopause.
So we wouldn't start at menopause, just again, because we don't want to, not everyone develops osteoporosis at menopause. So we wait for osteoporosis to develop before we start on treatment. Again, especially if we're going to be limited in duration of treatment for osteoporosis. We don't want to start it until we have to.
And then for our cancer patients, though, Dr. Ukrainski, we started a little earlier, right, when they're on high-risk therapies? Or
Again, we're really, we're monitoring a little bit more closely, but we don't really need to start until they have diagnosed osteoporosis or meet the other criteria by fragility fractures or things like that. So you don't have to start until they meet the treatment criteria.
okay, great. And then there's a question here on whether calcium carbonate or calcium citrate is better absorbed to help build bone.
So again, a lot of these things are, very individual. So calcium citrate may be better absorbed in patients who are on PPIs. Calcium carbonate also well absorbed if you're not on PPIs.
Another question here, it says that this person is in remission from breast cancer and had osteoporosis, osteopenia, is on Arimidex and gets Prolia twice a year. Also takes 5,000 milligrams of D per day. And the question is, when do you think this person can stop the Prolia and or lower the vitamin D?
So I'm not going to be able to answer when you can stop the Prolia because I would need a lot more information. But the vitamin D level, I would recommend, just following your vitamin D levels. If you're within the recommended range, most people can be maintained on 1,000 to 2,000 units. Rarely we do see patients who need 4,000, 5,000 units a day just to maintain the same level. So again, there's a lot of individual variability here.
And what about for bariatric patients? Is there a certain amount of vitamin D that they should take to ensure correct absorption?
So bariatric patients can have variable absorption. And again, there's that person-to-person variability. I have some patients with history of bariatric surgery who need like 10,000 units a day, every day for years to maintain a normal vitamin D level. Others don't need that much. So it really is whatever, we were aiming for 30 to 50 on the vitamin D and whatever is going to help keep you there.
And for the VTE risk, is it worth taking Raloxifene for osteoporosis?
We rarely use Raloxifene, to be honest. I think some oncologists will favor it because, there are some patients who benefit from Raloxifene if they have a very high breast cancer risk. The problem with Raloxifene is that it only reduces vertebral fractures, and most people don't have limited osteoporosis to the spine. They're usually going to have both spine and hip. So we're rarely going to pick Raloxifene because it only helps with the spine, reduction of spinal fractures or vertebral fractures, and especially because hip fractures are much more debilitating. So we want to make sure that we're going to cover both of that.
And what about for someone taking Fosamax? How many years would they normally stay on that therapy? And when they complete the therapy, would they go to an alternative medicine?
So the typical range for Fosamax can be anywhere from like 3 to 10 years. It depends on what your fracture risk is, what your DEXA scan was, have you had a fragility fracture, and then that would also determine, like if you have those really high risk features, you'd probably stay on it for about 10 years. And then depending on, how quickly you may lose bone mineral density on a follow-up after your drug holiday, or what if you're really, really high risk of fracture, you may start on something else like Teriparatide, just that tide you over to until you can restart the bisphosphonate. So drug holiday is usually for about maybe 2 to 4 years, and then we can restart it.
And if you stop it for, let's say that someone misses a couple doses of the Fosamax, is there a certain amount of time where they should just go on a holiday rather than starting back if they missed a couple months of therapy?
No, I mean, if you miss a dose here or there, you would want to restart it. If you had been off of it, if you stopped it and it's been like 2 years, we would check another DEXA scan to see if there's been any change in the bone mineral density, or if you're having a decline. If you're having a decline, we'd obviously tell you to restart it. If you had some improvement and that hasn't gotten worse, we could consider drug holiday.